Bismillahirrahmanirrahim. My name is Dr. Ashizia. Today the topic of my presentation is non-neurogenic lower urinary symptoms. The moderator of this presentation is Dr. Ghulam Mustafa. The learning objectives of my presentation are epidemiology of the lower urinary symptoms, symptomatology, IPSS, UFM, and post-wide volume. Lower urinary symptoms encompasses a range of irritative and obstructive difficulties. The phrase is purposefully gender non-specific and does not presume an anatomical site of origin for the symptoms. The LUTS is the commonest presentation in urology. It is a group of symptoms, not particularly a disease. The lower urinary symptoms are further divided into three groups: the storage symptoms, voiding symptoms, and post-maturation symptoms. The storage symptoms include urgency, frequency, nocturia, urinary incontinence. The voiding symptoms include hesitancy, intermittent urination, straining, and poor flow. The post-maturation symptoms include post-wide dribble and sense of incomplete emptying. There are a wide range of diseases that causes the lower urinary symptoms, from stone disease to bladder cancer, UTI. There are distal uteric stone, bladder tumor, uterus strictures, foreign body, urinary tract infections, neurogenic bladder dysfunction, chronic pelvic pain syndrome, nocturnal polyuria, overactive bladder, depressor overactivity or underactivity, and BPH. The definitions of LUTS includes the intermittency, defined as the interruption in the stream. The hesitancy is hesitation before the beginning of urination. Urgency is the urgent need to urinate. And the feeling of incomplete bladder emptying means a feeling that bladder is not still full after the urination. And nocturia is frequent urination, especially at night. There are basically three main reasons for the nocturia. The one is polyuria, the other is nocturnal polyuria, and then
थोड़ा पीछे वाली स्लाइड पे जाएं, यूरिनरी सिम्टम्स के ऊपर और पीछे एक स्लाइड पीछे, एक स्लाइड और। तो ये जो सिम्टम्स हैं, किसी को जो है वो डेफिनेशंस का पता है? व्हाट इज अर्जेंसी? उमेर?
When the person is unable to control
A good definition of urgency. Bilal?
The patient is unable to hold the urine and respond desire to urinate.
More better. It's right, but proper what examiners want to listen or one person want to express properly in it. Dr. Shersha? Urgency.
Strong desire.
What types? अपने आप को ना फंसाओ, डेफिनेशन कंप्लीट करो. A strong desire to void, which is a person is unable to postpone it. Okay. Frequency. Dr. Arsalan Shah. Dr. Arsalan Shahzad. When you will say it's frequent micturition?
maturation more than usual time.
What is usual time then? Dr. Riaz? When you will say that this is frequent maturation?
How many time maturate in 2 hours or 1 hour? Number of time.
In the absence of excessive water intake, if a person has space of less than 2 hours, or if a person is voiding more than 8 times in a day, then it will be significantly increased frequency. Okay, what is nocturia? When it will be significant? Fahad?
Nocturia basically urination during the night time, more than 5-6 times.
More correctly, more than 2, but what is more correct definition? Dr. Misal. Disturbance of sleep. You have to wake up from the sleep. Okay. Okay. And what about hesitancy? मतलब तो सब अभी प्रेजेंटेशन में देख चुके हैं ना जी डॉक्टर शेरशाह hesitancy
Start.
how much delay the better definition will be time taken by a detrusor to overcome the urethral resistance in starting stream. Okay. And what is intermittent urination? Why it is being caused? Causes क्या होते हैं intermittent urination के? Intermittent stream के? Fahad?
Sir, urethral stricture or self.
Stricture में intermittent stream होती है? Have you seen it commonly or not uncommonly? Arsalan Shahzad.
Large prostate, urinary tract infection. It may cause intermittent.
Ubaid, what causes the stream to interrupt?
Hyperplasia. So UTI also cause intermittency.
Enlarged prostate कैसे intermittency cause करता है डॉक्टर जफर? डॉक्टर श्रीजान.
As the patient applies extra abdominal pressure, the prostate, again, it narrows down the prostatic urethra, and then the urinary flow actually stops intermittently. And again, as it relaxes, the urination starts, and this process repeats, and that causes intermittent
Basically,
urination.
it's median lobe of prostate, which acts like a valve from inside out. When bladder contracts, intravesical pressure increases. Median lobe comes closer to the neck, and it causes a stoppage of stream. Then how UTI causes intermittency? Dr. Umair. It's basically the pain. Okay, and what other causes can be which cause intermittency, stoppage of stream? Stone blocking the neck. Okay. Continue presentation.
Nocturia. There are the three basic mechanisms for nocturia. The one is the polyuria, the other is nocturnal polyuria, and then bladder storage problems. The term polyuria defined as the urine production of 2500 ml or more than 2500 ml in a 24-hour period. The urine production is the 40 ml, greater than 40 ml per kg and 24 hours. The possible causes are diabetes insipidus and diabetes mellitus. The term nocturnal polyuria is the increase in nighttime urine production with decrease in daytime. Nocturnal volume is greater than 6.4 ml per kg are greater than 35% of total 24-hour volume. The possible causes are disruption of diagonal secretion of arginine vasopressin, sleep apnea, congestive heart failure, and lower urinary tract, lower stimulatory venous stages. In sleep apnea, basically, the soft tissues in upper respiratory tract relaxes. This causes the obstruction in upper airway. It results in increase in the concentration of carbon dioxide in body and decrease in the concentration of oxygen in the body. As a result, the blood pressure of the body increases and the body gets the false signal that patient is fluid overload, and the kidneys get rid of sodium and water, and the result increased production of urine at night. In the congestive heart failure, when the patient is mobile and performing the daily activity, there's a decreased blood flow to the kidneys. Hence, the kidneys retain the sodium and water. But in the night, when the body is relaxed, the blood flow to the kidney is higher, and the kidney gets rid of sodium and water. And the same mechanism is followed in the lower extremity venous stresses. In bladder storage problem, the possible causes are bladder obstruction, bladder overactivity, sensory urgency, infection, inflammation, and interstitial cystitis and malignancy. Another again causes of polyuria, diabetes insipidus, PPH, hyperplasia, excessive water consumption, alcohol, coffee, and tea, diuretic medications, overactive bladder, and heart failure. Now, the types of the incontinence and the type of incontinence. The urinary incontinence is defined as the involuntary passage of urine. The term stress incontinence means involuntary passage of urine with any activity that increases the intra-abdominal pressure. In stress incontinence, basically the urinary sphincter, there's a problem in urinary sphincter like a postmenopausal woman or a multiparous woman. In men, after radical prostatectomy or TURP, any procedure that damages the urinary sphincter. The urge incontinence means involuntary passage of urine coincident with the sensation of urinary urgency. It happens with cystitis or occult blood cancer, can also cause the urge incontinence. Mixed urinary incontinence. Patient have the urinary urgency with a loss of urine, and also there is a loss of urine with the Valsalva maneuvers. The term continuous incontinence means constant wetness in the perineum that is independent of the urge to urinate or maneuvers associated with increased intra-abdominal pressure. The conditions that causes the continuous incontinence are urinary fistulas that bypasses the outlet. So the history of gynecological procedures and radiation or traumatic childbirth is important, and some congenital condition also causes the continuous incontinence, like ectopic ureter or the duplex kidney that is running into the perineum or vagina. Pseudo incontinence. Some female patients experience symptoms that are similar to.
Can anybody tell what are the types of continuous incontinence? Dr. Yaz? It should be of two types, one with normal voiding and one without normal voiding. If a patient has continuous incontinence, continuous wet cloths, but it also has normal voiding pattern of urine, and other one is total incontinence with no voiding at all, and both have different types of pathologies. When as you heard that ureterovaginal fistulas, traumatic or ectopic ureters, the patients will have normal voiding from one side of the ureter, which normally opens into the bladder, and continuous incontinence from the ectopic ureter or the ureterovaginal fistula. And the other one is usually is observed in vesicovaginal or vesicouterine fistulas when there is continuously wet clots, but no pattern of normal voiding. Okay. Okay, continue.
Pseudo-incontinence. Some female patients experience symptoms similar to continuous urinary incontinence, but fail to demonstrate true urinary incontinence. The example of pseudo-incontinence is a chronic vaginal discharge. Patients may get confused with urinary incontinence, and there is another condition. It's called the phenophlebia. The phenophlebia causes the collection of urine in the vault of vagina, and that causes the slow leakage of the urine. Overflow incontinence occurs when the urine within the bladder exceeds the bladder capacity. Intravesical pressure is greater than vital outer resistance. It occurs in the condition like BPH. Functional incontinence. The patient with limited mobility or limited access to the toilet, they have intact anatomy and physiology and experience incontinence. Normally, basically, they have the normal anatomy and physiology, but they have a restriction, limited access to the toilet. It can occur in the patient with older age with poor cognitive abilities. The enuresis is urinary incontinence during sleep. It's called enuresis. It usually present in the 15% of the children up to 5 years of age. If it is due to ectopic presentation of ureter, it is called primary enuresis. If it is after the age of 5 years, it may be due to some psychological trauma, child abuse, bullying. Now, the evaluation of lower intake symptom. The ST is the integral part of the medical evaluation. It tells about the potential causes of lower intake symptoms and relevant comorbidities. The questions that need to be asked in the history of lower intake symptoms are diabetes mellitus, urological intervention, history of hematuria, history of previous urinary retention, burning maturation and febrile UTI, history of drugs intake, and constipation. And International Prostate Symptom Score, IPSS. This is the item of 8 questionnaire. The 7 questions are about the symptom of the disease, and the 8th question is about the quality of life. And they are graded from 0 to 5. The first question is, over the past month, how often have you had a sensation of not emptying your bladder completely after you finished urinating? Grade 0 is not at all. Score 1 is less than 1 time, and 5. Score 2 is less than half of the time, and score 3 is about half of the time. Score 4 is more than half of the time, and score 5 is almost always. The second question is, over the past month, how often you had to urinate again less than 2 hours after you finished urinating? The question 3 is, over the past month, how often have you found you stopped and started again several times when you urinated? The question 4 is, over the past month, how often have you found it difficult to postpone urination? The question 5 is, over the past month, how often you had a weak urinary stream? And the question 6 is, over the past month, how often have you had to push or strain to begin the urination? The question 7, the last question about the symptom of the disease is, over the past month, how many times did you mostly typically get up to urinate from the time you went to bed at night until time you got up in the morning? The score 0 is none. Score 1 is 1 time. Score 2 is 2 times. Score 3 is 3 times. Score 4 is 4 times, and score 5 is 5 times. And the question about the quality of life is, if you were to spend the rest of your life with your urinary condition just the way it is now, how would you think or believe about it? Delighted 0, pleased 1, mostly satisfied 2, mixed equally 3, unhappy 4, terrible 5. If the points in the IPSS is 0, the patient is asymptomatic. The points are the ranges between 1 to 7 points, the patient is mildly symptomatic. If the score is 8 to 19 points, the patient is moderately symptomatic. And the score is 20 to 55, the patient is severely symptomatic. The frequency volume charts and bladder diaries. The recording of volume and time of each void is referred as frequency volume chart. If there is additional information such as fluid intake, the use of pads, activity during the recording, and the grades of symptoms of severity and bladder sensation is called bladder diary. It should be long enough so the proper data is recorded. It should not be short enough so that it gives the false information about the data. So the bladder diary is kept for 48 to 72 hours. It gives the insight into functional capacity of the bladder and help to quantify the severity of nocturia. This is the frequency volume chart and bladder diary. And then comes the clinical examination that includes the abdominal examination, examination of the suprapubic area and genitalia, and PR examination. The PR examination or DRE, digital rectal examination, it actually predict about the simplest form of prediction about the volume of the prostate. But it is important that actually DRE tells about the clear prediction of the volume of the prostate when the volume of the prostate is less than 50 ml. If the size volume of the prostate is greater than 50 ml, then it may give the false information about the size of the prostate. So the transrectal ultrasound have a superior value over the DRE. Normal prostate is firm, smooth with palpable sulcus. The sign of BPH during DRE is enlarged, firm with palpable sulcus, and the sign of malignancies are hard nodular surface with impalpable sulcus. The investigation that we carry in the patient with low virgin tract symptoms are urine analysis. The urine analysis is the first test that we perform in the patient with a low virgin tract symptom. It gives the information about UTI, microhematuria, and diabetes mellitus. And then comes the serum creatinine, post-void residual volume, and UFM. Post-void residual volume is the amount of urine retained in the bladder after a voluntary void. The threshold of post-void residual volume is not defined. The volume less than 100 ml is considered within the acceptable range. The post-void residual volume can be assessed by ultrasound or Foley's catheterization. And the diagnostic accuracy of post-void residual volume measurement has the positive predictive value of 63% or the prediction of bladder outlet obstruction. Uroflowmetry or UFM, the patient has to write on this machine, and the data we get in the form of the chart. The following information we get is the flow rate, time to maximum flow rate, the voided volume, the average flow rate, the time, and the maximum flow rate. The maximum flow rate is known as the Qmax. The key components are Qmax and flow pattern. If the Qmax is greater than 20 ml per second, it means there is a low probability of bladder outlet obstruction. If the rates between 15 ml to 20 ml, then there is again a low probability of bladder outlet obstruction. But if the patient has a significant low intake symptoms, then the further evaluation is required in the rates between 50 ml to 20 ml. If the rates is less than 10 ml per second, then there is a suspicion of bladder outlet obstruction, urethral stricture, or urethral impairment. It should be evaluated with water volume greater than 150 ml. So 150 ml volume is required for the proper presentation of UFM. A threshold of Qmax of 10 ml per second has the specificity of 70% and positive predictive value of 70% and sensitivity of 47% for diagnosis of bladder outlet obstruction. And then comes the PSA. This may be ordered when evaluating the male patient for prostatic disease, including urinary obstruction, BPH, prostatitis, and prostate cancer. Basically, PSA also gives the information about the volume of the prostate. It is a strong association of PSA and prostate volume. Was found in a community-based study with positive predictive value of 78%. If the PSA value is about 1.5 nanogram per ml, it means the prostate volume is likely greater than 30 ml. The PSA again changes the course of treatment from medical treatment to surgical intervention. Imaging. The ultrasound or upper tract assessment, it can be used for the evaluation with large post-wide residual volume, hematuria, and the history of urolithiasis, or to exclude the urolithiasis. And imaging of prostate is required when considering medical treatment or when considering surgical treatment. Widening cystourethrogram is useful for the detection of vesico-ureteral reflex, bladder diverticulars, and urethral pathologies. Again, retrograde ureterogram is for suspected urethral strictures. Urethrocystoscopy is performed in the patient with a history of gross hematuria, urethral strictures, or bladder cancer who present with LUTS should undergo urethrocystoscopy for diagnostic evaluation. And then come the urodynamics. The indication of urodynamics is the perform pressure flow studies only prior to invasive treatment or when the further evaluation of underlying pathology is required. Perform the pressure flow studies in a patient who had previous unsuccessful invasive treatment for LUTS. Perform the urodynamics if the patient considered treatment who cannot void greater than 150 ml. Perform the pressure flow studies when considering invasive therapy in a man with bothersome predominantly voiding LUTS with post-wide residual volume greater than 300 ml. Perform pressure flow studies when considering invasive treatment in patients with bothersome predominantly voiding LUTS aged greater than 80 years. Perform pressure flow studies when considering invasive treatment in patients with bothersome predominantly voiding LUTS age less than 50 years. And there is a assessment algorithm of the LUTS in men aged 40 years above. The patient, male patient, come with a complaints of LUTS, then history, the sexual function, symptom score questionnaire, urine analysis, physical examination, PSA if diagnosis of carcinoma of prostate will change the management discussed with the patient, and measurement of post-wide residual volume is determined. If there is a bothersome symptoms, then frequency volume chart in the case of predominantly storage LUTS or nocturia, ultrasound assessment of the prostate or UFM is performed. If there is a benign condition of the bladder or the prostate with baseline values, then planned treatment, surgical treatment according to the algorithm, or medical treatment according to the algorithm. If there is a significant post-wide residual volume, then ultrasound of the kidney or renal function assessment, then again we will perform the FEC, ultrasound assessment of the prostate, UFM, then it we can decide accordingly about the medical treatment or surgical treatment. If there is abnormal diarrhea and a suspicion of neurological disease, high PSA or abnormal urine analysis, then evaluation is according to the relevant guideline or clinical standard to underline condition if any otherwise return to the initial assessment.